All right, everyone, let's go ahead and get started. For those of you that are online, my name is Jeff Beck. I'm one of the interventional pain physicians with Wellspring Pain Solutions. You can see several of our different locations on the bottom of the screen there. I believe this is mostly marketed towards the Terre Haute region, but we also have locations in Bloomington, Columbus, and Batesville. I'd also like to invite you, if you have any questions throughout this discussion, to pull your cursor over the bottom bar there and you can insert a question and try to give us a good stumper. All right, next slide. All right, today we're going to learn about some different therapies for chronic back and leg pain. Some of these things that you've probably heard of before, some of these things might be new, um, and it's going to be real important to talk with your primary care provider and referring provider about some of these options. All right, next slide. Um, I think one of the most important things that we look at when we're talking about pain is to help describe the symptoms and the location. Some of the most important questions that we want to ask people are, is the pain just in your back? Is it in your legs? Is it achy? Is it throbbing? Is it weakness? We want to know what exacerbates the pain, what alleviates the pain. So those are things we're going to be important to figure out what the right treatment is. Next slide. When we're talking about chronic pain, some of the main things that we're talking about is not just pain reduction, but a lot of times, even more importantly, is functional improvement. So, you talk about basic functions around the house, work, playing with children or grandchildren, higher level functions such as walking, hiking, gardening, and then even sexual activity with your partner. So these are different functions that are important in our lives. Next slide. A lot of these treatments are more common ones that primary care providers and a lot of you have probably been exposed to. When you're talking about treatments, you always want to start with the least invasive, which would be simple medications, whether they are non-steroidals, nerve pain medicines, narcotics, non-narcotics, physical therapy, different nerve blocks and epidural steroid injections, and even some implantable pain devices, as well as surgery is obviously the last option when you're talking about treatment options. Next slide. So these are the three main topics that we're going to touch base on tonight. The first one is radio frequency ablation. The second one and the primary one of tonight's talk is some interspinous treatments for spinal stenosis. And then the last one we'll talk a little bit about is spinal cord stimulation for people with chronic and intractable pain who have had surgery or are not candidates for surgery. Next slide. Yeah, so radiofrequency ablation. This is a treatment that actually involves targeting a specific nerve in your back that supplies these little joints in our back called facet joints. And these facet joints can get arthritic, just like an arthritic knee. But these joints in the back typically cause a lot of pain when you're upright standing, twisting, extending. Um, but in this situation, the pain is mainly in your low back. So one of the ways that we can help identify if your pain is coming from those joints is to do a diagnostic block with a local anesthetic. Now, if you're able to achieve really great relief with those diagnostic blocks, then you may be a candidate for this radio frequency ablation. This is also done with just a simple needle to the back that hooks up to a generator, and that needle tip um, heats up to 80 degrees Celsius, and we burn that little nerve branch for 90 seconds. It's primarily a sensory nerve branch. It doesn't affect your ability to stand or walk. It just helps with the pain. So that's a really great treatment option. Unfortunately, those nerves can regenerate. So that procedure, if it's really effective, can be repeated around every year. Next slide. So this is the bulk of the procedure or the bulk of the treatment that we want to talk about. It's the Vertiflex procedure. It's really revolutionized the way that pain providers think about some of our patients with pinched nerves. Next slide. So the kind of patient that would be a candidate for this treatment, to contrast it with the radio frequency ablation where patients just have back pain. In this kind of patient, they may have arthritis, but that arthritis causes a narrowing around the nerves in your back. So the longer that you stand and walk, that nerve tissue continues to get compressed, and the nerves will send out signals telling your brain that they don't like that. And so that's why you'll see a lot of people when they have this stenosis where the back pain kind of goes across the back and then the pain goes into their legs the longer they stand and walk. You'll see like on the right side of the screen, they have to sit down. They're always looking for a chair. Or the people at the grocery store or Lowe's, they're bending over the shopping cart. And that helps open up that space to take the pressure off the nerves so they get a temporary relief. Next slide. Yeah, so we were already talking about this for what lumbar spinal stenosis is. This is, a narrowing of where the nerve tissue lives. You can see down here on the bottom left, where that's a healthy person. Their spinal canal in the middle, it's wide open. There's not a lot of arthritis. Things can kind of breathe naturally in there. But the patient there on the right of that, they have a lot of arthritis that's built up, and that can cause pinching of the nerve tissue in the middle or on the sides. Now, you can get symptoms in both legs from the center being pinched, or if just one of the sides is pinched, you can also just get pain in that left or right leg from pinching in the sides. And again, when you're bending forward, that really helps open up those spaces and gets pressure off that nerve tissue. So that's where this procedure comes in really handy. Next slide. So yeah, here you'll see this animation on the right side, but really how this procedure is done, typically we take you off to a sterile room, typically at an ambulatory surgery center, and you're given some deep sedation through your IV, or in some cases it's done under general anesthesia. And once your back is prepped and you're totally comfortable, we make a really small incision, no bigger than probably the width of your thumb. And through that hole, we can insert really, I'll just call it a tube, as you can see on the right side there. And through that tube, once we're at the level to deploy the spacer, you can see that spacer going in. And then once it's in, we can actually open up those prongs to hug the spinous processes back there. So that's those bony prominences you see sticking out on the back side. And those prongs make it provide kind of the suction or the sticking mechanism so that device stays in the middle. And then it also makes it so it can't retract back, because once those prongs are deployed, if you went down there and tried to pull on it with um, basically some sterile pliers, you couldn't move it. That's how well it gets stuck into place there. Okay, next slide. Yeah, so this just summarizes some of the stuff we discussed before. So we kind of just described the procedure, how quick and easy it is. You know, the alternative to that procedure traditionally is a what's called a laminectomy. So that is a general anesthesia surgical procedure. That procedure is done typically in the hospital under general anesthesia, and that procedure done by a spinal surgeon can leave you in the hospital for a few days. The nice thing about this procedure is that, based on, depending on the facility, you get there an hour before your procedure. The procedure time is maybe booked for 45 minutes or an hour. And then you're discharged home, probably about an hour after the procedure. So you're going home right away with minimal pain. One of the things that we use to help minimize the pain after the procedure is we give you some medicines, both non-narcotic and narcotic, as well as an abdominal binder to really help provide that support. So that's really a game changer, when in the past, a lot of these patients needed to be treated with a more traditional surgical procedure. I'd also mention that, there are many patients in the advanced aging population that they cannot get cleared for a traditional spine surgery. That's where we can come in as well and place this device to act as a stopper and kind of jack up that space to get the pressure off the nerves. And that can be done in patients who are um, um, much more higher risk, because the procedure is so much more minimally invasive. Next slide. Yeah, so this is kind of more of the same. After the procedure, I talked about wearing an abdominal binder. You'll have a small dressing over the incision. Again, the incision is, I don't, maybe an inch. It's no bigger than the width of your thumb. You'll wear that abdominal binder for around 2 weeks when you're up out of bed, just to provide that extra support. Um, we do recommend not a lot of repetitive bending and twisting for the first few weeks after the procedure, so it can stay fixed in place, minimize any chance of the device migrating, because that is a potential side effect, although very low risk. Um, so overall, it's a pretty minimally invasive procedure. Next slide. Uh, and again, this slide here is kind of more of testimonials about patients and how well they do. You have patients getting into their golden years who really have difficulties moving and walking. So again, some of the ways that we evaluate how well patients do is with a screening device, a questionnaire called the Zurich Claudication Score. And that questionnaire was utilized over 5 years in patients in this research study. And it's really profound that, you know, patients will start developing a significant improvement in symptoms around 2 to 6 weeks. And a lot of patients continue to keep getting better up to the 6 month point. And in the patients they studied out to 5 years, the results were durable, which means the treatment was initiated, the patients got better, and then the patients stayed well up until that 5 year point. And when you're talking about literature and research, anything that you can study through 5 years and is still durable is without doubt an incredible treatment. So these patients, they had a significant reduction in their pain, they had the ability to function better, and majority of them that were on opiates had a decreased need. Now, it doesn't mean that patients could do whatever they wanted. We're looking at goals of I can stand and walk for 5 minutes, and now I can stand and walk for 25 minutes. That's very meaningful, and that really improves patients' pain and function and quality of life, mental health, and well-being. Next slide. All right, so next treatment is neurostimulation. This treatment's been around for many, many years. So we're going to talk about that next. Next slide. So neurostimulation is a really novel treatment that's been around forever. And by forever, I mean 30 to 50 years. The technology advancements and the applications have gotten so good, and the costs have come down so much that now that those treatments and even newer treatments beyond what we're talking about today are going to be more readily available to the general population. So when, again, to compare the other options, when we're talking about neurostimulation, we're talking about working on the neural tissue. So these patients are typically going to best respond when they have hip pain, leg pain, burning pain, tingling, sensations that are nerve related. Um, uh, those are the patients that are going to be our best ones to target. The other the other great indication is chronic regional pain syndrome or reflex sympathetic dystrophy. That's another approved FDA approved diagnosis for this treatment. Next slide. Next slide. Um, yeah, so as you can see, I said 30 to 50 years. There it is. It's 40 years. It's FDA approved for what's called failed back surgery syndrome and chronic regional pain syndrome. One of the nice things about this is, when you're in a pain clinic or even primary care clinic, you have patients on a lot of medications. They've done shots, they've done physical therapy. What are the next steps for these individuals? So these are some of those things that we're talking about, and it's widely covered by insurances. And like I said, the technology has gotten so good over the past 10 years that it's a lot more readily available to individuals. Next slide. All right, so this is how spinal cord stimulation works. If you can see this slide very well, really what you're seeing on that individual's body is you see basically a little circle on basically their left buttock or left lower flank. And there's a wire that's going into their spinal area. It's actually sitting in the epidural space. And what this shows is it is actually sending basically electronic signals to a certain area in the spine that helps modulate pain. So the pain that's coming from in this individual, maybe their right buttock and leg, um, it's blocked from sending that signal up to the spine by using these fancy electronical signals. So we're really using the body's um, own program to kind of trick it from feeling that chronic neuropathic pain. Next slide. So really what we're looking at here is how do we know if spinal cord stimulation is for you? Well, number one is you typically need to have a good diagnosis for it, and that means you've had one or more back surgeries and you still have chronic severe debilitating pain, or you've not had a back surgery and you've seen a spine surgeon and they say, your back's just too bad. Surgery is probably going to make you worse. Um, or you have chronic regional pain syndrome. So those are the scenarios that you're looking at for the right diagnosis. Once you've hit that, you have to have a conversation with the patient about, what are my goals? Well, the patient and the physician have to both be comfortable with um, with the permanent implantation of the device. If you're going to go through with this device, if I'm going to implant this into you, it's kind of like a marriage. you put this device in someone, you're kind of you're kind of locked into that relationship. So you want to make sure that you're only putting this in people who it's going to work really well. So you really want to make sure the patient has good expectations. We want to make sure that they're getting good pain relief, at least 50%. If it's less than 50%, you have to really start wondering if that's going to be the right treatment for them. You don't just have to have pain reduction. If it allows you to generate a significant amount of function, and function can be standing, walking, sleeping better at night. A lot of times patients will talk about, I was able to stand and cook a meal all the way through for my family for the first time in years, fill in the blank. The other goal is to decrease the need for narcotic or non-narcotic medication, because some of the non-narcotic medications can cause side effects as well. So those are kind of the three parameters we look at: pain reduction, function improvement, and decreased need for medications. And so at that point, once we've done the trial, the patient and provider both have to really be comfortable with the goals and the expected outcomes, because there's nothing worse than providing this service to someone who doesn't meet their expectations. It's always frustrating for everyone if and when that occurs. I think we have a short video to play for a example of a patient. Stacy, you can play that for us.
Hi, I'm Mitsumi from Morsel, Indiana. This is my wife,
Sunita Sumi, also from Warsaw.
I've lived with my pain before we even got married. It's been over 20 years. I've tried a lot of different things to cure it. Nothing just seemed to work. It just kept getting worse.
I work on concrete, and I lift a lot of heavy plants and move a lot of heavy things around. And it got to the point I couldn't even walk. We couldn't play with the grandkids anymore. We just went to work and came home and became zombies, just sat here and did nothing.
I actually had a blow-up mattress here on the floor, and that's where I would come and stay because the pain was so bad.
After trying many different things, Dr. Roth did suggest trying the Boston Scientific spinal cord stimulator.
When they did the trial thing, they do it in the office, and it's very simple. And as soon as I got it turned on and they set my device, I knew right then because my pain was gone. I mean, I haven't felt that way in years. So it was really nice to actually move without any pain. But the day of the actual implant,
Mitch is like, well, do it on her first so that you have practice before you do it on me. And so I did. I went in first, and then he had his. So we got done, came home. A couple of days later, he decided to go to work.
Started our new life. I mean, it's nice after we had this done that you could actually pick up your grandkids.
The little 1-year-old, we can keep up with her now. They want you to play ball, and they want us out there when they're on their swing sets and on their toys. And so we can actually do that now with them. And it's been so nice.
I know I keep saying it's a miracle, but this thing is just unreal.
Our life's so much easier. We do laugh a lot more than we used to,
A better life.
Yeah.
All right. Well, that was really powerful, and videos like that are really really amazing, and that gives providers like me probably the most satisfaction of anything that we do. This just kind of talks a little bit about how we can set up the device. Each of these different devices, they have these electrodes. They have these leads with different electrodes on them. So you can set them up so to have different kinds of stimulation. The most common now is paresthesia free, which essentially means that we set these devices up at a frequency that allows you to get pain relief without actually having sort of any of the kind of the buzzing sensation. Traditional, what we call low density stimulation, typically kind of has that buzzing type of sensation where the buzzing, it's real low level, can block the pain, but um, as time has gone on, this paresthesia free stimulation seems to be the most beneficial for patients. And a lot of times they're not, patients aren't even sure if it's working because because they don't feel it, right? So they're wondering if it works, and then you tell them, well, turn off your device, and then their pain comes back, and then they realize, oh wow, that was working. So that's kind of been the biggest advancement, is getting that stimulation paresthesia free. It's allowed a lot more people to tolerate the treatment. Next slide. This just talks about the long-term safety and efficacy of the device. Um, on the right side, you see these bar graphs where the height is pain. The left side basically shows patients with significant severe disabling pain. They undergo neurostimulation or spinal cord stimulation, and still 2 years after the device has been implanted, they're having significant relief. Now, I will, mention that 8.6 to 2.98 is not pain-free, but again, that's all about getting the appropriate goals and expectations set up with your patient, because if you have a patient who wants to go from an 8.6 to a 0, and you deliver a 2.98, if they feel like that's a failure, then that's a problem. So we want to make sure you have good expectations, and the expectations are you're going to get good relief. Are you going to be pain free? Probably not, but your life is going to be better. Next slide. All right, so that's all I have for this evening. You can certainly visit our website, wellspringpainsolutions.com. Like I said, we are in multiple locations, Terre Haute, Columbus, Indiana, Bloomington, in Batesville, Indiana, and we'll be opening clinics in Greenwood and up in the Carmel area soon. If anyone has any questions, you can scroll down to the bottom. There's I believe, a Q&A button or a chat button. You can type something in there, and I'd be happy to try and answer the question for you. But if you want to also just schedule an appointment or contact the office for questions, that's also fine.